Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Cyclosporine. It is isolated from soil fungus Tolypocladium inflatum gams. Coming to its formulations, available in capsules 25 mg and 100 mg, oral solution 100 mg per ml. It won't cross blood-brain barrier. It will cross placenta and even found in breast milk. Reaches peak within 2 to 4 hours. Bioavailability is 30 to 50%. It is highly plasma protein bound, that is 90%. It is bound to albumin. T-half is 5 to 18 hours. It is extensively metabolized in liver by enzyme CYP3A4. Excreted via bile, because it is extensively metabolized in liver, excreted via liver only, bile 93%. About 6% only excreted via urine. Coming to its mechanism of action, mainly immunosuppression. In Switzerland, they are in search of an antifungal drug, so they have isolated this cyclosporine from fungus. Soil fungus Tolypocladium inflatum gams. But later it was found to be a weak antifungal, but fortuitously, that means fortunately it was having a high immunosuppressive action. From then they have been using this drug for prophylaxis of organ transplant patients. Now we are using in dermatology. What is the mechanism of action? Cyclosporine binds to cyclophilin. This complex goes and inhibits calcineurin. Same like tacrolimus, if we inhibit calcineurin, it inhibits nuclear factor of activated T cell, which downregulates the expression of interleukin 2, T for T cells. Ultimately, T cells will get inhibited from getting activated and from being proliferated. Hence, getting the desired action, immunosuppression. It also inhibits ICAM1. Coming to its uses, FDA approved uses are psoriasis, which is very severe, disabling, recalcitrant. Recalcitrant means very difficult to treat, and treatment resistant psoriasis, atopic dermatitis. Coming to off-label uses, immunobullous diseases like pemphigus, bullous pemphigoid, linear IgA disease, epidermolysis bullosa acquisita. Autoimmune connective tissue diseases like scleroderma, dermatomyositis. Granulomatous diseases like sarcoidosis, granuloma annulare. Neutrophilic dermatosis like Behçet's pyoderma gangrenosum. Chronic spontaneous urticaria, photodermatosis like chronic actinic dermatitis, papillosquamous disease like lichen planus. FDA approved use psoriasis, off-label use lichen planus, lichen planopilaris, alopecia areata, papular erythroderma of O-Fu-G. In this disease, there will be intensely itchy papules symmetrically distributed all over the trunk, but skin folds are spared, looking like a deck chair. So there will be a classical deck chair sign in papular erythroderma of O-Fu-G. Morphea prurigo nodularis, Kimura's disease. In Kimura's disease, there will be painless subcutaneous nodules over face and neck. In both papular erythroderma of O-Fu-G and Kimura's disease, there will be peripheral eosinophilia. Coming to contraindications, absolute contraindication is severe renal dysfunction, uncontrolled hypertension, because in cyclosporine there will be increased risk of nephrotoxicity, which leads to hypertension. Hypersensitivity, as usual for any drug. Malignancies. Relative contraindication, pregnancy and lactation, as it is a category C drug. Controlled hypertension, active infections, as we are suppressing immunity, and immunodeficiency states. Already we are giving immunosuppressant. So we have to check whether the patient is having already immunodeficiency, whether the patient is on corticosteroids. They are all relative contraindications. Drug interactions, as it is extensively metabolized in liver via enzyme CYP3A4. Whichever drugs influence CYP3A4 like enzyme inducers will make CYP3A4 function more and eliminate cyclosporine. So cyclosporine levels will reduce. Enzyme inhibitors will not affect cyclosporine metabolism. So cyclosporine will be there very high without getting metabolized. In one of my drugs video, I have clearly told what are enzyme inducers, what and all are the list of enzyme inhibitors. This list you should be having in your fingertips so that you can apply on any drug which is extensively metabolized in liver. I have clearly explained difference between grape and grapefruit also with images. Adverse effects of cyclosporine. Remember last word porine. Porine, urine. First you have to write nephrotoxicity. Irreversible interstitial fibrosis may occur or reversible disruption of glomerular filtration may occur because of renal vasoconstriction. Afferent arterioles will get constricted, leading to reduced glomerular filtration, which is reversible. But interstitial fibrosis is irreversible. Whenever you hear the word fibrosis, it means already the normal tissue was replaced by fibrous tissue. Nothing can bring it back. Hypertension. Either it may be due to direct renal vasoconstriction or it may be secondary to renal dysfunction because of this fibrosis. How do you treat this hypertension? With calcium channel blockers. You should never give ACE inhibitors, ARBs, angiotensin receptor blockers and potassium sparing diuretics. Why? Hyperkalemia can occur with cyclosporine itself. All these drugs will elevate the risk of hyperkalemia. Next adverse effect, hyperuricemia, hepatotoxicity at high dosages, hyperlipidemia. Diet modifications or lipid lowering agents we have to prescribe along with cyclosporine. Hypertrichosis, mostly it is concerned for females because males will have already full of hair all over the body. Even if some more hair grows, no problem. Only for females it will be awkward. Gingival hyperplasia, hypomagnesemia. CNS side effects like paresthesias, tremors, headache, malaise, nausea, all will self-resolve within weeks, not a problem. Coming to investigations and monitoring, now we have seen what are the adverse effects. Based on that, we should derive which investigation is important. CBC, LFT with enzymes, RFT, particularly blood urea nitrogen, fasting lipids as it causes hyperlipidemia, magnesium, potassium, uric acid. Blood pressure and serum creatinine should be checked twice a day apart before starting cyclosporine. Follow up bi-weekly for 2 months, then monthly once. Each visit we should check BP compulsory. If serum creatinine has elevated by 30% from baseline level, then we should reduce the dose by 1 mg per kg for about a 1 month and repeat serum creatinine. If it is not reducing, still persisting at 30% above the baseline value, then we should stop the drug. Or at first time itself, it has elevated to more than 50% from the baseline, you should stop the drug. Again, when the serum creatinine comes to normal, then we can restart the drug with lowest dose possible. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.